For many years, it was clear that the evaluation of the depth of response was relevant, and the concept of complete response was a clear marker for predicting long survival. However, complete response is based on suboptimal markers. One is the morphology, and with morphology you cannot discriminate between a normal and a myelomatous plasma cell, and the other marker that used for complete response is electrophoresis, then paraprotein. But we know that there are non-secretory myelomas that don't produce the paraprotein. Therefore, we need good markers, sensitive markers, to discriminate between the normal and the malignant plasma cell. This marker can be immunophenotypic markers or molecular markers. The immunophenotypic markers are based on a constellation of antigens that allows you to distinguish the malignant cell, the malignant plasma cell, from the normal plasma cell. The molecular is based on the BDJ rearrangement of the immunoglobulins. Both are like the fingerprint of the tumor cell. These two tools has been implemented for more now than 15 years, but they have caveats, and one of the caveats was the sensitivity and the reproducibility. The sensitivity with both markers using second generation flow or using ASCO PCR was around 10 to the minus 4. This means detection of a malignant cell in 10,000 normal cells. But now the good news is that we have the next generation flow and the next generation sequencing that allows you to detect one malignant cell in 1,000,000 normal cells. And we know that this matters because the lowest the level of residual cells, the longest the survival. In this meeting, I'm going to show that both methods are reproducible and equally effective in predicting survival. Let me explain myself a bit on depth. We have shown, and we are going to present in this meeting, that the patients that achieve 10 to the minus 6, less than 10 to the minus 6 residual leukemic cell have a longer survival, whatever method you are using. Even this apply for patients with newly diagnosed candidate to transplant and the non-candidate to transplant as well. Even more, in the non-candidate, probably this is more relevant. And the reason why probably is more relevant is because these patients, usually the critical point is the initial response, because some of these patients just get 1 or 2 lines of therapy, different from the transplant. In addition, we have been able to demonstrate the value of eradicating minimal residual disease in patients at the time of relapse. In the relapse patient, with both techniques, you can also predict survival. And one of the probably more challenging data that we have observed is the value in the high-risk population defined by cytogenetics. In fact, if you are a standard risk, but you still have residual tumor cells, the outcome is worse than if you are high risk by cytogenetics, but you eradicate the residual tumor cells. Nevertheless, minimal residual disease in the bone marrow analyzed either by next generation flow or next generation sequences is not the end of the story, because the bone marrow infiltration in multiple myeloma sometimes is focal infiltration. For this reason, I like to say that what is bad is to have minimal residual disease positivity. This means that you have disease. Unless you have a very strong immune system, you will relapse. This is something that is clear. MRD positivity is bad, but MRD negativity is not always good, because in some occasions, the reason why it's not negative is not because it's a true negative. It could be a false negative due to the patchy infiltration of the bone marrow. Myeloma is different from leukemia. In leukemia, you have a diffuse infiltration, and it could be that the sample that you have got is not representative enough of the bone marrow. For this reason, we need another tool, a complementary tool, and this is the PET scan. And the goal in myeloma treatment will be to achieve an MRD negative by flow or by next generation sequencing plus a PET negative result. And in this meeting, I also will highlight that many cooperative groups have decided to include as an endpoint the minimal residual disease. The endpoint for me is that MRD positive result should force you to change the treatment, to try to get a different drug combination in order to eradicate this resistant clone. And I think this is how we are going to work in the near future.